Right, everybody. Everyone ready? I'd love to allow us to carry on doing loads of chatting and connecting, but we're under a little bit of pressure to make sure we all get our lunch downstairs in the restaurant. So we better kick off the next section. It's a really good section, this next one. We've got a lot of speakers from the floor, and after you've done your talk, if you could sit at the front as well. So over the course of this session, we'll have 8 or 9 people, I think, might need another chair, sitting at the front. I don't promise to ask you all a question, but hopefully we'll be able to get a good conversation going at the end. We're talking about personalised care. Liam's going to talk about GP, pathway referrals. We're going to hear about people's types of roles they do. And what I want to get into is a bit of discussion about where we need to get to into the future. There's an acronym soup of different roles, ANPs, AHPs, SCPs. There's all manner of different things, all with their own, as Nick calls, a fiefdom of who's in charge and how they've got to have these roles. We need perhaps a more simplified structure. Everyone understands about how people do these advanced roles. I don't even know why they call advanced roles, or people should just be able to learn new skills and then be an equivalent member of the team. So I think some kind of rebranding is probably where we need to get to. We might get into that in a discussion, but first off, we're going to start with Liam, who's going to talk about primary care and pathways. Thanks, Liam.
Thanks, Dave. Good morning, everyone. Still just morning, isn't it? My name's Liam Hosey. I'm a GP in the centre of Wigan and also the Cancer Lead GP for Wigan locality. I'm here because I've had quite a significant part in the development of this Van Can project, which we will talk about a little bit more again today. I think Scott's perhaps the most talked about man who's not in the room, isn't he, at the moment? But thanks so much for the opportunity to come here and talk about some issues around primary care. I'm suitably now nervous. I'm in a room full, I think, of secondary care colleagues, and I'm a GP trying to talk to you, so be gentle with me, all right? So I guess what's happening in primary care at the moment. So we all know there's lots of different GP practices across Greater Manchester and lots of different GPs and associated professionals working in those practices. What we have had over the last few years, though, is the development of PCNs, or primary care networks. Now, these are groups of surgeries that are geographically closely located to each other and work at a collaborative basis together as primary care entities. And the basis around that is they can sometimes share resources and work at economies of scale. And a good example of perhaps what PCNs did achieve quite successfully was the delivery of COVID vaccines, so we could work quite closely as practices together and do those COVID vaccines in a more efficient manner than doing it in each individual surgery. The other good bit, though, that PCN networks have done with the help of the team from Greater Manchester is they've managed to nominate a PCN cancer lead for each PCN. That's either a clinician or an appropriate other person, so quite a senior manager within that primary care setting, that's the go-to person for information given for that PCN. That really is very useful in actually helping us distribute some information to primary care. Sometimes it's not about the message that's being given, but maybe who's giving the message. So we could have a really eminent tertiary care professor saying, you must do this, GPs. That message might fall on deaf ears, but if you have a really trusted local GP saying the same message, we may just get a bit more uptake of that message. Also, each locality, or most localities, have a GP cancer lead. So as I said, I'm the one for Wigan, and we have one in many other localities in Greater Manchester. This is a state of flux and change at the moment with the formation of the ICB. So when CCGs sort of ceased being and became part of a big GM system, there's a consultation taken place recently that's just finished waiting for the outcome of that, where clinical leadership is being looked at. I think it's pretty clear that there'll be a difference in roles in a few months' time for cancer lead GPs such as myself. I'm not quite sure I'll be funded, i.e. resourced to the same number of sessions that I do in my Wigan role at the moment. That creates a challenge going forward, I think. So I think each locality may have a cancer lead, but they may be doing it as well as doing some other things as well. So I think just bear that in mind with local service development. It's very similar to CCG cancer commissioning managers as well. They did exist, and they still do exist in locality forms, but employed by the Greater Manchester ICB. And again, some of those names will have changed when people have swapped jobs or moved jobs with the change to an ICB. And finally, we've got the Greater Manchester Cancer Alliance Early Diagnosis Team, which is a team that quite simply has grown and grown and grown in strength over the last few years. And I will talk a little bit about some of the work they do in the next few slides. But just to say, I think they're an absolute asset to our system. So one bit I think most of us are probably aware of in secondary care is GP referral forms, okay? And this has been a real labour of love. And actually, referral forms have probably existed in some form or other for a number of years. Many localities developed their own forms and things were chopped and changed a little bit. And one of the many things we can probably thank COVID for is actually saying, well, it did help standardise some processes. So in those horrible days of March and April 2020, there was a suggestion, wasn't that some of our patients had to be referred to any hospital across the region to get their cancer treatment or cancer investigation. So what we needed to do is standardise that referral format, if you like, and send the required amount of information. So these are where these forms really did develop and gain legs. Now, they're not perfect, okay? Sometimes it can be a bit of information dump into secondary care, so lots of coded data and lots of stuff. Think, crikey, what does this mean? But it's probably better than nothing. It's probably better than the old-fashioned way of, this person has some urinary symptoms, please see and advise. They're the ones I used to send to Dave, obviously, but no longer. But they do follow nice guidelines, okay. They allow us as GPs to actually say what we should be referring. It helps us look at these thinking, well, actually, that doesn't quite fit the guidelines or the pathway. Maybe I need to do something different. And the forms are continually reviewed by cancer leads and also by commissioning managers. Now, I did allude to PCNs a few minutes ago, and one of the things that's actually all PCNs are part of is signing up to the early cancer diagnosis. And there's lots of bits around early cancer diagnosis, and I will talk about a few of those in a few slides' time. But there's a really relevant bit for urology within the PCN cancer diagnosis, and that's to increase the diagnosis of prostate cancer, specifically concentrating those individuals that are at risk of developing prostate cancer, which are in the sort of middle bit of the slide there. Now, primary care IT systems can, when they work, be quite intelligent, okay? So we can pull out searches to identify patients quite easily about who may be at risk. So we can look at age of patients, that's pretty obvious. We can also look at ethnicity of patients. We can look at those patients who've got a coded family history. So if my dad, for example, had a family history of cancer or prostate cancer in his notes, then I could be identified as somebody who may be at risk. What the suggestion was, we could send out a text message to those patients, sort of a reasonably neutral sort of form of words, as you can see on the slide, that say you may be at risk of prostate cancer. Please check your prostate cancer risk on the Prostate Cancer UK risk checker. Now, anyone who's actually done that risk check, if you type in the right demographic, it will say you're at risk of prostate cancer. Please see your GP about getting a PSA test, or please discuss that with your GP. So it's just a way into maybe prompting some people to come forward as to us as GPs. So what? So actually, when we've done some of that, what we had to do is educate some of our primary care colleagues around that. And this has been a real eye-opener. So I'm standing here as sort of not really an expert. I'm a day-to-day job in GP. I'm a 6-session GP partner in my surgery. I've been a cancer lead for about 10 years in Wigan. I think my only other urology qualification was to do a 3-month house officer job when they were a thing in 2001 at North Manchester doing urology. But that was my extent of my urology training, if you like. So some of the stuff about people being at risk of prostate cancer isn't something that was actually emphasised for us as GPs. We've had to learn and teach this a little bit. So if you had somebody come in front of us who was of a black ethnicity, for example, a lot of GPs or primary colleagues might, well, so what? Okay, so we've really had to sort of raise that awareness of that. There's these infographics that are shown on the slide there that the education team have produced that gives a real nice sort of bite-sized way of looking at some key facts, and it maybe sort of helps dispel some myths as well. So, for example, doing PSA testing, we're not wholly reliant on people's symptoms. I think we all know in this room that many patients can have very significant prostate cancer without having lots of symptoms, and perhaps as GPs, what we're doing is batting people away before saying, well, you're not having a PSA test because you've got no urinary symptoms, so go away. And, actually we're challenging that sort of approach. So I think already we've heard today some of Molly's work with the Cancer Academy and some of the stuff that Alex has talked about how this is part of an ongoing education programme. What I've also done as part of the Cancer Alliance and also to help support the PCN DES is something around the clinical decision support tool. So I think Alex alluded to a little bit of this in her presentation at the start. So what we are meant to develop is some decision support tools that help us in primary care IT settings. Now, I could talk to you all day about how difficult it is to be a GP, but what we do as GPs is see illnesses at a very early, undifferentiated stage. So let's take something urological, for example. Let's take urinary frequency. That could be anything, couldn't it? Okay, it might be a sign of cancer. It may actually be a sign of diabetes and the wean a bit more. Okay, it may be electrolyte imbalance. It may be because we've stuck the patient on some diuretics and they're peeing more. We've got to start working that out. Let's take other things like weight loss, for example. Okay, there's a whole multitude of things that could be or might be. What these decision support tools do is run in our clinical systems to help think and prompt us of cancer. So if you can see this as an example, if we typed in something like weight loss, for example, this message then pops up on our screen to say, you've entered a symptom code that may indicate cancer. Do you want to know a bit more about this? And there's some things you can click on that either bring you to some of these infographics that I showed before, or some referral forms, for example, or some other web pages that will give you more information to think cancer. Ultimately, you can close it down as well. So if you don't think it's appropriate, you can just click no and just progress with your consultation as it goes on. But it's a way of making us in primary care just think about these really important issues. So what's the benefit of that approach? And actually, it's something that's reasonably cost efficient in a way. The IT stuff has been developed that, and it can run in clinical systems, be updated very, very easy by those clever people who work in primary care IT. What it also allows us to do is pull more and more data from our clinical systems as well and start working how many people are actually using them and how many more referrals it's created, etc. And we can use the sort of links we've described before with PCNs, etc., into sort of disseminating that information further and get more and more practices to use them. Now, finally, I did promise this, didn't I? We can't have a presentation today without talking about the VanCam project. I think Alex has already talked, I think, very eloquently about what this project is. But I think just to expand a teeny weeny more, this is an NHS England case finding project. What it isn't is PSA screening, okay, because I think you could have a whole day on that, couldn't we? This is about targeting people within our communities who, as Alex said before, are less likely to perhaps present into primary care, to encourage them to come for a discussion around PSA testing. So the way the project works at the moment is this van, and there's literally a picture of the van there, is going around our communities in places that are close to where that patient lives, so in supermarket, car parks, in community centres. The GP practices that in the areas that the van is in a few weeks before are given notice of this, and they can send out text message to their patients they can identify with their search system to say, you may be at increased risk of cancer, prostate cancer. This van is coming. You can book an appointment to go on the van and have a chat about PSA testing. This has been co-designed with lots and lots of appropriate people. Okay, so there's been some clear, input from primary and secondary care clinicians on that, but also people from the voluntary sector and various charitable organisations as well. So we've got a real broad church of people inputting into that. It's purely about PSA testing, though. So if the patient turns up and says, I've got loads of low urinary tract symptoms, I've got hematuria, I've got loads of weight loss, that's very outside the scope of the van. But what we do with that patient, we've given them a sort of printed letter to take to their GP saying you need to be seen urgently to evaluate this further, etc. So we're really conscious of the fact that some of these patients, that might be the only time they touch into healthcare services, and we don't want to lose that opportunity. And I think perhaps, in maybe 6 or 12 months' time, when all the sort of findings of this project have been evaluated, it'll probably be yet another session to run here at some point. I'm sure Scott can talk much more eloquently about that on live TV later on today, can't he? I'm sure we can scream it, can't we, as you say, Dave? So I think that's probably me, if that's all right. I think we'll probably, as you say, Dave, take some questions at the end, if that's all right. So thank you.
Thanks. And Liam takes the hot seat. Be feeling very visible there as some of you will as we go through. Because next up, if we can bring to the front, please, Sally and Laura. We're going to talk about the role of the CNS. And I guess it's not just the CNS now, it's the CNS perhaps of the future. So thanks very much.
Dave, how do I move the slide on? Was it listening to that?
Press that or
Which one?
go on that one. Yeah.
Oh, smashing. Right. So, hello everybody. My name's Laura. This is Sally. And we're specialist nurses at Salford Royal. And looking around the room, I can see there's quite a few specialist nurses here. So I'm sorry if we're telling you what you already know, but I think it's probably useful if there is some consultants and doctors in this room just to recap actually how hard we work. All right. So I guess that's the message I'd like to get across. So what we know is that any patient diagnosed with a cancer should have a key worker. And the aim of that is to provide support at diagnosis, assessment of information needs, advice on treatment options and side effects, managed side effects that might occur. We also provide support to the families, to the friends of the patient, and signpost. And we all know that we play a crucial role in looking after the patients and the family when they're on their cancer journey. So, responsibilities. So we act as a key worker across the whole patient pathway, and that can be very, very long. We have advanced clinical and diagnostic skills. We're constantly evolving, and we have in-depth knowledge of the tumour area that we cover. We have a good ability to assess patients' holistic needs, and this is very, very much in the format of what we do now and is really important. And we also have advanced communication and advocacy skills. And we play an important part within the MDT, and we also work closely with other cancer charities, Macmillan, for example. The patients that we're managing are becoming more and more complex, and the needs of the patients are constantly changing, as is the needs of the family and the friends that support them on the cancer journey. We very much provide nurse-led services that free up our consultants and our doctors to see more complex patients. And we quite often will intervene and manage treatment side effects and support patients with any symptoms that they're experiencing, and also when they have unplanned admissions. And of course, we're trying to empower patients to manage their condition, which can be difficult. And within Salford, we're constantly sort of encouraged to review our services and look where we can do service improvement and get patient satisfaction and feedback. And of course, supporting the patient in the choice around the treatment and the care. Challenges, right. So I guess I just wanted to home in a little bit about this. We've recently reviewed our services. We did a 12-month annual report, and we got the data analysts involved who pulled all our nurse-led data. And any specialist nurses that are in the room, I would really, really encourage you to do this. It was really, really eye-opening at how many patients we actually saw within our nurse-led clinics. And I think when we presented it to our consultant body, there was quite a bit of realisation from then at how hard we actually work and what we contributed to our department and our service. What we saw that there was a 75% across the 12-month period in the requirement for our CNS services. We looked at the number of new diagnoses in each tumour group from the 12-month period from November 21 to November 22, and it increased basically by 236 new from the previous annual year. We noticed that when we looked at all our nurse-led clinics, the number of patients that we were seeing was just going up, in particular around our novel hormone clinics, and that really just sort of ties in with all the new agents that are coming through. And these patients are really complex, who are managed on abiraterone, apalutamide, all these new agents. They need monitoring, they need care, they need looking after, and in particular, they're generally quite advanced within the disease, so they do have more symptoms. So we really noticed this. And all the data that we took, we were quite satisfied that it was all accurate. It was all pulled from electronic patient records and from the Somerset Cancer Registry. Right, so the challenges, and I know that we've probably touched upon this morning in the various presentations that have took place, but we know we've got an ageing population. We know people are living for longer. And more so within our area, we've seen that managing patients' expectations is just becoming really, really difficult. And within our department, there just isn't the capacity in our numbers to manage it. Patients want more, they expect more. They've gone through this period of COVID where they've probably felt unsupported and out on their own, and then they're coming back into services, and the demand of what they want is just increased. Within our department, we've had an increase in our urology consultants. So I think we've had
2 or 3,
probably, yeah, in the past couple of years, 3 more consultants employed with no specialist nurse input at the side of that to manage the service that they're bringing in and those patients. So from our point of view as a team, looking at the data and analysing it was really, really important. And I would be very happy to share it with any specialist nurses that are in the room, because I think it would be really useful for you to do in your areas. And of course, we know we've got this issue now that who are going to be the specialist nurses of the future in urology, because certainly at Salford, we don't have a urology ward. There is no, urology nurses. When I started, I worked on a fantastic urology nurse. My mentors sat there on the second, table down all those years ago. And I knew that that was what I wanted to do. But they don't have that now. They're not out there, these urology nurses. And it's really difficult. So we wonder who are going to come into these roles. So this is just a little snapshot of our cumulative activity. So bearing in mind there is 4 of us oncology nurses who cover nurse-led clinics, different tumour areas. I'm part-time, Sally's full-time, Hannah's part-time, and Siobhan is full-time. So, that's a lot of, say April 22, we saw 330 patients in a month nurse-led activity. So that could be from novel hormones, ED clinic, BCG clinic. So that's our actual numbers. So when we sat down as a team and we looked at that, it was sort of this moment where we thought, bloody hell, we worked really, really hard. Do you know what I mean? We worked really hard. And this is not taking into account your key worker interactions, your patients that drop into the department who want to speak to you, or your patient calls, which again is another massive amount of work that we do. This is how we feel. I did share this with my colleagues at one of our meetings. She stood in the storm, and when the wind did not blow her sails, she adjusted her sails. We are constantly adjusting our sails, and it's. I'm sure some of the other nurses in the room will resonate with this. That's very much how we feel. Right, so I'll pass you to Sally, who's just going to share a case study. Is that okay? Yeah.
We thought it was important to perhaps share a patient's story, because at the heart of everything we do is a patient, isn't it? And it's nice to bring that in the room. The other thing we wanted to share was, although Laura showed all the data and all the things that we do, these are all the things that we do for the patient. And this is about a gentleman who was age 61, diagnosed with a prostate cancer, Gleason 4 + 5 = 9, diagnosed in 2021. He had negative staging scans, and his proposed treatment was for 2 years of hormones and external beam radiotherapy. And his past medical history was hypertension, some fatigue, joint pain, but thought to be sort of from his arthritis. His social history: he lived with his wife, he continued to work as an engineer, full-time, non-smoker, minimal alcohol intake. So the patient received his first hormone injection in April 2021. And his first time back in our clinic was after his completion of his radiotherapy, still continuing his hormone therapy, and that was in the January of 2022. So how did we help him? Well, he had significant fatigue from his hormone therapy, although he did have a little bit of fatigue from before. So we discussed conservative measures to combat this. We gave him the Prostate Cancer UK fatigue booklet, and we gave him some steps to help with it. He had hot flushes with his hormonal treatment, so we gave him advice to avoid caffeinated drinks, the use of fan therapy, and medication if necessary. He also had an emotional strain to him, so we signposted him to Prostate Cancer Support and Macmillan Information Centre Services and St Anne's Hospice for B&U therapies. Depression caused by his hormone therapy referred to counselling services for further support and GP, and he's now receiving cognitive behavioural therapy weekly at the moment. He had pain to his joints, he gained weight around his girth, and again, we signposted him and referred him to the Can Move exercise programme to help combat with his fatigue and to help with his well-being. His sleep patterns were impacted, and his quality of life was also impacted. So we gave him practical solutions to help and setting goals to achieve. He also had erectile dysfunction, and he commenced on different medications and therapies to help him through with the support of our team. And he's found comfort in seeing the CNS on a 3-monthly basis for help, support and advice, and just knowing that we were there for him. Usually we don't see these patients for sort of 6 to 9 monthly, but for him it was really important. And again, that impacted on our appointments, trying to fit him in to see him. He had taken early retirement because of all these symptoms, and we signposted him again to the Macmillan Support Centre in regards to his personal independence benefits and support benefits. He developed lots along the way from his radiotherapy, with 1 hourly frequency and 2 times nocturia. Further assessment and management arranged to help with this, and he started on some medication. And that's it. But that just brings together, that's just one patient in a whole cohort of patients that we were helping. So if you times that by the number of patients that we're seeing, it's a whole lot of work that the CNS role does. And I think that's sometimes hidden within our role. We talk about other things, but that's what the heart of the patient is, what we do. Thank you.
I'm sure the patients love the work that you do. Probably you're more popular than the doctors and other workers, I'm sure. Okay, loads of questions there. I love the fact that your presentation leaves more questions in my head than answers you've given. Very provocatively positioned presentation. Really good. Next up, I think making his way down the corridor here, Secret Service-like, is Craig, one of our senior trainees, and he's going to talk about the role of non-consultant doctors in the service, how much great work they do as well alongside the nurses and so on in terms of delivering the service. So Craig, over to yourself. Thank you.
So thank you for the invitation really to come and speak. So as has been said, my name's Craig Jones and I'm a specialty trainee. So I'm just going to be covering the role of a trainee is. As trainees, we often just go through a conveyor belt from start to finish and don't really think about how we impact teams that we work with or patients. So it was an interesting exercise really to reflect on. But I currently work between the Christie and Salford because I'm out of programme doing some research, but I'll be back in the fold in about 6 weeks. So I'm just going to do a general introduction to the shape of training. So there was a big move to redesign the curriculum for surgical trainees. And how does that look now? So how does the old money of SHO, specialist registrar, actually compare to all these new acronyms of CTs, CSTs, STs, OOPR, all those kind of things? So we'll cover that. And what specifically are the cancer training requirements for trainees? As we've heard, cancer referrals make up 40% of patients coming to the clinic, and that's a huge amount of workload. Therefore, there's a huge amount of experience and knowledge that as trainees we need to develop during our time. And what are the key procedural and surgical skills? So there's obviously a lot about communication skills and knowledge, but really with the European Working Time Directive and the rush to kind of get people through to consultancy, it's condensed the period at which we're exposed to theatre and to caseload quite dramatically, and COVID's obviously had its effects as well. But what opportunities can trainees bring? What do we add that's different to the rest of the workforce? So we're often the first patient that a patient sees when they're newly referred in the outpatient clinic. We might see them when they present to A&E acutely or as a complication of their treatment. We undertake a lot of the diagnostic workload, so the flexible cystoscopies, trust biopsies, urodynamics, and so forth. And we try as much as we can to get to theatre, but we appreciate this is only a small part of actually our training requirement. And a lot of it, and particularly in the early years, is spent face-to-face with patients, with their relatives on the ward. And then we also get involved in follow-up. So we really cover the whole breadth of patient interactions in a secondary care setting. So we embark after we leave medical school on a period of foundation programme. This was where I was inspired to become a urologist. I did a 4-month rotation in urology and was inspired by the people I worked with and the exposure to the range that we as urologists deliver. So that's a minimum of 2 years. And then you embark on your core surgical training, which is now phase 1. So the shape of training, designed it into 3 phases. Phase 1 being generic surgical skills, phase 2 being more specialist surgical skills, and then phase 3 being higher specialist skills. And in order for you to move on from your core part, the phase 1, you need to sit your membership exam at the Royal College. So you're having to juggle that additionally with your clinical work and training commitments. And then you embark on your phase 2. So this is your kind of your bread and butter core urology. But then as you move into phase 3, there's the opportunity to take these specialist interest modules, which in cancer range across all the cancer domains from prostate cancer, bladder, renal, testis and penile cancer. And we're very fortunate in the Northwest to have access to the Christie as part of our training, where we can be exposed to some of these more rarer cancers. In the latter part, we'll then sit a fellowship exam. So this is quite a big exam, big hurdle to overcome. It typically takes about 6 to 9 months to prepare for, and it's in your evenings and weekends. But once you get on the other side of it, it's then about rounding yourself off really and trying to get yourself in the position where you can then be a day 1 consultant. And particularly in cancer, we see that a lot of trainees embark on a post CCT, which is that certificate completion of training fellowship, where they fine-tune their skills further. As we're doing more complex surgery on the robot or complex open surgery, then we can fine-tune those skills. And with the ultimate goal then of becoming a consultant. And at each of these, at the end of each year, we have what's called an ARCP, which is an annual review of competency progression. And it's important that we meet all the requirements of the syllabus. So there's so many acronyms, I've had to write them down. What are the generic professional capabilities, GPCs, which link with the GMC, good medical practice. And then there's the capabilities of practice, which are things like can the trainee manage individuals in an outpatient setting? Can they manage them in an emergency setting? Can they do it on an inpatient setting, and so forth? And then what happens is your supervisor will collect all the information from multiple consultants in the form of a multi-consultant report, and then this is reviewed annually to assess whether you can progress onto the next phase of training. Now, what are the cancer-specific training requirements? So, as I say, in clinic, we need to kind of not just understand the diagnostic pathways and treatment pathways, but we also do a lot about preoperative counselling, surveillance strategies, and there was a hot topic at BAUS just this year talking about should we obtain written consent for patients going on to surveillance. And as more and more treatment options are available, it's becoming much more challenging in the time constraints of a busy clinic to actually counsel patients appropriately. And one of my interests is really cancer survivorship. So we've heard how the cancer nurse specialists are doing a lot of the follow-up clinics, but a lot of the complex patients are still seen in the clinician-led clinics. And a lot of them aren't necessarily in relation to their cancer diagnosis, but more consequences of their treatment or some of their toxicities that they're experiencing. We've touched on the fact that patients can present acutely, and one of the kind of those nightmare situations that always seems to happen on a Friday evening at about 5 or 6 p.m. You get that phone call to A&E, patient's in retention, they've got worsening back pain and reduced mobility, and you think, right, is this metastatic spinal cord compression? But this can often be the first person that the patient is told that they might have cancer, and it's a life-changing event for those people. So I think it's important that we, as trainees, have as much exposure to it, even though it may be rare. But working with colleagues, we can improve. We've touched on the fact we do a lot of diagnostics, and really where we try to get as trainees is often the surgical caseload, because this is one of the harder things to actually get exposure to. But we're involved not just in the procedures themselves, but in case selection, preoperative counselling, positioning of the patient, which when you work with 4 or 5 different consultants and everyone's got a slight difference of where they want the pillow positioned, it took me about 6 months of working with Professor Clark to actually get it right. And then we start off learning. Jeremy's shaking, I've still not got it right. We often learn first by watching and assisting, and then we get into the nitty-gritty of operating. But we work as part of that team, that theatre team, where we're working with the anaesthetists, with the surgical care practitioners, as we're about to hear about. But really, we also need to be on the wards, and it's very easy as an early year surgical trainee to want to be in theatre all the time, but our responsibility is to our patients, and the operation is a small period which the patient won't remember, but you'll remember. But actually what they remember most is that period before and after, which is when they're on the ward. And we try and reduce the time that they're in hospital by enhanced recovery. Oh no, what have I done? I've gone to slide 290. How do I go back? That's one way to finish the day very quickly. Pressed end. Oh no. They weren't on my slides, you'll be glad to hear.
I think we'll be filling your inbox with all these slides, will we?
Yeah, there we go. I was there somewhere.
And then obviously we form part of the multidisciplinary team, and that will differ between where you work, but at Salford, the trainees and the junior doctors are the key people who present the case and highlight the relevant and salient points for discussion. In terms of surgical skills, we often learn doing endoscopy and then move on to more complex laparoscopy. And really, I'm a firm believer that actually training should be when you are exposed most to the complex open surgery to really develop those key surgical skills, which are then translational. The name of the procedure is simply what someone's decided to term it, but the skills that you learn are all translational, whether it's a small kind of scrotal operation like a hydrocele repair to doing a more complex operation. The actual mechanism by which you do it is fairly kind of consistent, just in terms of the length of the operation. Obviously, when you're doing a 7-hour operation, you need to build up stamina as well. And now we're seeing more on the robot, and a lot of centres have invested time and money into a second console, which not only means that it's essentially like two people being able to fly a plane together. It's how airline pilots learn, and it's how surgeons of the future and surgeons now are learning, where you're actually seeing the same thing as what the person who's teaching you the operation is able to see, and then you can hand control over in real time, so that if anyone's getting to a hairy point in the operation, then the consultant who's in charge can just take over control at that point if it's felt necessary, without having to move, reposition, or anything like that. They can be videoed. So when I started doing robotic surgery, I was able to video and play back my cases with my consultant, and that's a real opportunity for learning. So I think as trainees, we're going to be exposed more and more to the tools, not just the tools of the robot, but the tools of video assisted learning and feedback. And what are the benefits of having a trainee? So we rotate annually, generally. We bring new ideas, new ways of thinking, and we bring new energy and motivation. There's often people get kind of worn down by the heavy machinery that is the NHS, the bureaucracy of management, and just that kind of general attrition. Sometimes it just needs someone new, and often a trainee is a good person to bring new ideas. It does have its challenges, and that often, when someone's worked in a unit for 20 years and they've seen the same trainees come in, bring the same idea and go, well, good luck. It can be a bit challenging. But I think that new energy, that motivation can be a really good thing. And we often drive some of the audit processes. So we bring it from departments that we worked at before, and then we can also compare across our network. And I also think research is key to improving care for our patients. A lot of our trainees are taking time out to undertake a higher degree, and that the skills that they then learn can be implemented into our practice to help generate data, which ultimately will improve patient outcomes. And we're also very fortunate to have an academic clinical lecturer in the region, and hopefully with that we'll see a progression that will get more and more research, more and more output, and raise the profile in the region. I'm very fortunate that as the first trainee member of the Pathway Board, it's given me an insight into the metrics of cancer in urology. Often we just do what we do and we don't necessarily think about the bigger picture, and being part of the pathway board's really given me insight as to how things are measured, how targets are set, and also how we can work together as a region to improve care. So down the road, where they're, as Kieran said, where they may have a 95, 100% success rate in one area, but only a 10% in another, we can learn from each other, and that idea of collaboration is key. And as trainees, we don't have any allegiances. We're essentially undertaking a 5-year job interview where hopefully someone will appoint us at the end, but we don't have any allegiances, so we can break down those political boundaries. So yeah, thank you for the talk. And as I say, we're part of the wider team. But if anyone's got any questions about how trainees can be better, either if you don't have a trainee in your department and you're thinking about how you can help trainees, then just let me know.
Thanks, Craig. Emphasising energy, feeling valued as part of the broader team, another theme we've had, and also career development, which is essentially what you're doing as a trainee, isn't it? Developing new skills, and that's the theme that's relevant to all professionals in terms of motivation in particular. Right, next up, we've got Nick here, who's going to talk about surgical care practitioner work, SCP. Thank you, Nick.
Okay. So I think it's probably the first time Dave's actually got my title right. But as I said, I'm a surgical care practitioner. I'm just going to explain what that is and then how my role sort of works. So I work at Salford predominantly, but also Rochdale Infirmary across the NCA and potentially Bury in the future, who knows. But this is just my journey, a bit of background, how I became an SCP, obviously registered nurse by background. But as you see, I ended up doing urology and theatre. And so whether we talked about the urology ward dying out, urology surgery is still obviously happening in theatre, and the SCP generally, the breeding ground for that role is usually theatre. So the fact that we are still producing SCPs, I think will carry on because they're exposed to the surgery, and then they get to introduce to the other side of the process of urological surgery. So obviously I did an MSc in surgical care practice at Edgehill University, and the diagram there, the image there is the old curriculum, because there's now been a revised curriculum, but it's based on work-based assessment, so it's you're learning on the job effectively whilst also doing your MSc, and end up with a QI project at the end, which I'll talk a little bit more in a minute. SCPs are part of the Medical Associate Professions group, so that's the same group as the Physicians Associates and the Anaesthetic Associates. So we're in that bracket, which is a little bit confusing because the difference is, to be an SCP, you have to be a registered practitioner, where obviously the PAs and the AAs, it's slightly different. They have a thing called direct access. As I mentioned, the curriculum review, and that is the new curriculum, and it's the Royal College of Surgeons for England and Edinburgh have come together for this, which is a big thing for the SCP community because there was a division. There's actually 4 colleges of surgery. England and Edinburgh, the 2 main ones, it seems, and they were sort of slightly divided with the Royal College of Surgeons in England doing my curriculum and Edinburgh offering sort of some educational stuff and faculty. But they've now come together and working together for our good, and they've developed a managed voluntary register between us. And the reason for the managed voluntary register for SCPs, because one, we don't know how many there are in the country. We guesstimate between 500 and 800 SCPs across the surgical specialties. Because obviously, you may be aware that PAs and AAs are going to be regulated by the GMC. The SCPs were, at the time of that consultation, decided not to be, because we were already registered either by the NMC or the HCPC. But that's something that the both Royal Colleges are still pushing for. But that would involve SCPs having direct access. So going away from that second point, being a registered practitioner. Lots of discussion, lots of politics, as Dave sort of alluded to before in these things. So, but as surgical care practitioners, quite often we see ourselves as being advanced practitioners, which is, for those advanced practitioners in the room, I'm not sure how many there is, it causes a bit of consternation. So when we talk about, I mean, Dave mentioned what is advanced practice to a point. It's a way of quantifying a level, I guess. And they talk about the 4 pillars. So the new SCP curriculum talks about the 4 pillars as well. We brought it into that domain. We're still in the MAPS group. And the whole question is, are we advanced practice or are we a MAP group? That's going to rumble on for us for a number of years, I would imagine. But these are the things that we're sort of built our curriculum on. So SCP activity. So this is just a generic sort of throwing out there what some of the things SCPs can do. As you can see, theatre, clinic and ward. So we can be the surgical assistant, the assistant to the consultant or to the trainee, helping them with their surgery. So specifically for me, around robotics sometimes, or any big open cases, reconstruction. But we can also be the primary operator. So an SCP can actually do surgery. That's the whole point of the part of the course. And it tends to be maybe the more straightforward, simplest operations. Hydrocele, for example, as Craig mentioned, that's something that could fall in our remit. And the process has been signed off for this. In regards to clinic, very much like maybe the advanced clinical practitioner or advanced nurse practitioners, or those sort of things, those new patients, follow-up patients, usually with a bent on a surgical pathway. Be involved in diagnostic clinics, for example, like flexible cystoscopy, even being involved in doing transperineal biopsy. That's maybe seeing the patient, deciding do they need a biopsy, going through the whole process. Regards to the ward, you can see in post-operative patients, sort of do the reviews, even work in sort of surgical admission lounge, surgical admissions unit, should I say, doing ambulatory sort of renal colic stuff. That's where they can work, and in some places they do. And in some places, God forbid, they can even work on the on-call rota, something that I'm not advocating, Mr. Shockley. But in certain centres, and it's more about service needs. So all these things will vary depending on, but the SCP can work in these three domains, and it's around service requirement, really. This was a bit, you probably won't really be able to see very well, but this is an audit that we did in 2019. We actually sent it out. It was published a couple of years ago now. But this is sort of some of the aspects of what the SCP can do. And with the graph on the left there, you can see that there's a variety of clinic activity that they can do. And I say the on-call rotas have presented this somewhere else recently, and one of the medics picked up on the on-call rota was quite low for urology. And I said, well, that's probably, since then, I know of at least 3 centres that are utilising them more and more for the on-call rota. So this is my job plan. Again, I'm not sure well you can see it. So it works on a sort of a 4-week rota. Weeks 1 and week 3 are the same, 2 and 4. And you can see a mixture there of theatre activity. I get a bit of admin and audit, which is very reliable. And really do need that. But also you can see PGW is the Penton Gateway. It's where I go, one of the centres we go to do some outpatient clinics. So I have a penile scrotal clinic. And P&E is percutaneous nerve evaluation. It's the trial phase of sacral neuromodulation. So I do that independently, as well as a local anaesthetic vasectomy clinic. But that's a procedure clinic. So looking at the 3 domains, theatre, this is me. So I get to patient side, robotic assistant on a Monday with Mr. Madanini. So that's my every Monday, usually where I would normally be, sat next to that machine, trying to dodge the arms as he takes lumps out of kidneys. Sacral neuromodulation, we're a regional centre at Salford, and I'm one of the implanters, along with Miss Foster, who's on mat leave at the moment, so Mr. Clark is covering that. So I get to do some of the surgery, both implanting and also the trial phase. Dave Ross, my clinical mentor, so I do a bit of endourology, so a bit of stones, and Dave there was asking why I wasn't coming to his theatre anymore. This is, you see my job plan, you see why I can't get there. But obviously I quite enjoy doing ureteroscopies and laser ablation. It's great. Scrotal surgery, that's both maybe doing some of the surgery, but also being the assistant. Reconstruction more as an assistant, and open surgery as an assistant. So clinic, again, Penton Gateway, penile scrotal patients, getting to see them, assess them, list them up, counsel them. The P&E that under local, so I'm seeing these patients for the first time on that day, assess them, but ultimately under local put a nerve, and that's that image in the middle in case you wonder what I'm talking about, putting a needle in there, S3 frame and putting a lead in there and see if this helps with their overactive bladder or female non-obstructive urinary retention. And obviously they're about doing the vasectomies under local anaesthetic. Ward cover, limited involvement, which is where I like it. My background, you saw, is theatre and clinic. So wards is probably my weakness. But we've got another SCP with us who, we talked to Helen, she quite liked the ward, I think, and was very, very good at it. But her background was theatre and ward, so maybe better skilled. But obviously, there's an option to do stuff. I mean, it can be expanded, and in some places, that's what they'll have a more of a large event. And again, it's more about service need. So obviously, we talked about those 4 pillars. So we're talking about, you've seen what the clinical side I can do, but obviously, leadership and management and audit all come into play in the role. So quality improvement projects, developing. You can see there, I've been involved in a few things. I was involved in the development of the transperineal biopsy. When we first started to do it a few years ago, I actually started doing the transperineal biopsies myself. I got about 6 done, and then the robot turned up, and that changed my job plan to become the patient side assistant from being the person doing the biopsies. Been involved in a bit of research. That's the basic study was around about trialling a new lead for the percutaneous nerve evaluation, and obviously various audits involved along the way. Education, that's my education, also educating other people. So obviously IRMA training, so I can order scans, done my non-medical prescribing. I'm now a lecturer at Edgehill University teaching on the SCP course, which is quite interesting actually, being on the other side of the fence. And obviously it's leading to potentially doing a PG cert in education is probably potentially next year's plan. I think leadership and management, we're all involved in it to a point, but that's part of my role. So trying to develop the service. I think Dave's already got a plan for my next development. We had a little chat before about something else. But we're always looking to develop how can we improve, and the conversation's going with what Kieran was talking about, how we can deliver services better. That comes under there. I'm being involved. And sometimes as specialist nurses and SCPs or physician associates, we may see a different angle to the medics and say, well, I can do that. Why don't we develop this? And so it gives you a chance to do these things. So this is my management as it works, because obviously I'm a nurse by background. So Julia Taylor is my consultant nurse. So she manages me as my line manager, if you like. And Dave Ross is my clinical supervisor. So he manages me from my skill set, I guess you could argue, from the operating side in particular. And it works quite well, although I've got to meet them next month for a double appraisal with them at the same time. One interesting point, of course, with any of the roles that be advanced nurse practitioners or advanced clinical practitioners or PAs or SCPs, is Twitter can be a dangerous place to go on. If you go on there and you'll see this is the SCP's turn to get a bit of bashing from some trainees. And I say trainees, it tends to be, I think, at the core trainee group. And as Craig has explained, the system for training for junior doctors or trainee doctors, I should say, it's that CT grade where they don't get access sometimes to theatre. And I remember as a scrub practitioner, the SHO coming to theatre. Rarely do you see the CT grade doctors coming to the theatre. I didn't necessarily understand why that was. I thought just wasn't interested, but it's a lot of it's to do with that work-time balance. So if they do come, I'm always mindful that they've come on their day off or they're 0 hours. So we are trying to accommodate them, and I try and teach to the SCP community that support them, because ultimately I'm interested, Craig being the best surgeon he can. He could be my consultant tomorrow, so it's in my interest. I don't want to be working along someone who's underskilled, undercooked, because there's no fun at being that assistant in that situation, believe me. But these are the things that are out there that we've experienced. Obviously, I'm obviously trying to promote the role of the SCP. I am the chair of the Association of Surgical Care Practitioners, and we've got involved in various meetings. It's HE, it's actually NHS England now, but involved in that development of practitioners around this group, and obviously able to present at various shows and things. Just a few publications, I don't really see that. But that's for me done, I think. Thank you very much.
Yeah. Gosh, you do a lot of stuff, don't you, Nick? I get also highlighting the tensions that these new roles can portray. You just touched on the end about the trainees and how you're taking work away from trainees, stuff to learn from trainees. So it's not an easy road developing career pathways where people can take extended roles and there's more blurring between primary secondary care or doctors, nurses and AHPs. But I think we're all agreeing we do need to do something in that space. So thanks very much, Nick, for that. I'm sure we'll come to you for questions in a bit. Next up, we've got 2 more before we're doing our little panel. Andrea's going to talk about personalised care. So quite a lot of progress in personalised care. So thanks very much, Andrea.
Thank you. So is it just the forward arrow before I go right to the end?
Yeah, just press that one. Or you can use that one.
Oh, I'll use that one then, I won't end it. So So thank you very much for inviting me today. As it says, I'm Andrea Webber, Personalised Care Manager at the Alliance, and I've got 10 minutes today to talk about personalised care. And I could actually talk all day, it's such a huge area now, but I'm going to narrow it down to just giving you a brief overview of what personalised care is in relation to the Alliance's work and an overview of patient stratified follow-up. So before I do that, I just want to let you know a tiny bit about myself because I'm relatively new to the Alliance, but I have previously worked at the Christie for the last 20 years. My last role was in digital services in a project type position, designing and building electronic forms and then supporting teams in the rollout and the use of those forms. It's been a really interesting move for me to the Alliance and working with the whole of Greater Manchester rather than just the Christie itself. And it's really widened my perspective on cancer care and how we need to work together, not only as trusts across Greater Manchester, but also with patients to put them at the centre of their care. Whilst not on a cancer pathway, I have been through the health system for the past 16 years with my daughter. And if her care had been personalised, even in a slight way, life would have been much less stressful and a little easier for everyone. And this has made me especially passionate about personalised care because I can see what a difference even small changes could make. At many points throughout her care, if somebody had just listened to us and looked at her as a holistic, all her needs holistically, then life really would have been better. So I also want to say, and this was mentioned briefly before, that I've never worked anywhere where there are so many acronyms. And I apologise for using them in my presentation, but there are many in personalised care. So I'm going to try and use the full name at least once, but I apologise if you don't quite understand which document I'm referencing. So what is personalised care? So where appropriate, every person diagnosed with cancer will have access to personalised care, including a holistic needs assessment, an HNA, a personalised care and support plan, a PCSP, and health and wellbeing information and support. So when you ask patients and carers what cancer means to them, it's not always just about the tumour. In fact, their cancer may not always be the most important thing to them. It's just one thing sometimes in many things, and it can affect them physically, emotionally, and financially. And personalised care focuses on the person as a whole. If you imagine a bottle of Coke and every time you have a stress, you shake it, whether it be your cancer, your treatment, late effects from that, financial problems, family problems, lack of support, eventually that bottle is just going to bubble over. So we're trying to match the best medical care with the best quality of life for the patient. And we recognise that personalised care means different things to many different people. And over the years, it's been through many different iterations and names. But as an alliance, we're stripping it back to look at where we are against delivering the NHS long-term plan ambitions. And there's been a lot of good work done over the years in trying to standardise the delivery of these interventions so that all patients are at least offered them. But it's clear there's big gaps and varying levels of quality, which we want to address fully before broadening the scope beyond successful delivery. It's not just about increasing numbers, it's about increasing the quality of those offerings as well. So we've co-designed this graphic with a number of our patient and carer representatives, and it's been shared in multiple forums with a lot of positive feedback. It took us quite a long time to try and summarise personalised care into one infographic, but it's showing that the personalised care should start before the patient's even being diagnosed, with a long-term ambition to increase genomics testing both before and after diagnosis. The HNA, PCSP, treatment summaries, the cancer care review, which is the CCR, and the health and wellbeing support are all intrinsically linked. There's no point having a really good quality PCSP to find that there are no services offered that support a patient's concerns. Likewise, there's no point doing a holistic needs assessment if that's just a box ticking exercise which is filed away and never acted on. So how do we ensure that everyone receives the same quality? Well, the first thing we need to do is put the patient at the centre of our personalised care programme. We can't deliver this successfully without them. They're the people that know what they need, and we shouldn't be making any assumptions about what that need is. We need to educate patients so that they know what's out there for them and how to articulate themselves to ask for it. And we also need to educate the workforce. We need to make sure we have effective communication channels, not just reaching out to the general population, but really drilling down into communities and delivering our messages in the way that they want to hear them. And finally, where we can, enabling technology to help. So that brings me on to my next slide of patient stratified follow-up, or PSFU. So we're using technology to implement a remote digital monitoring system across Greater Manchester using stratified follow-up. Implementing a system across Greater Manchester and having everybody use the same system has not been without its challenges, especially around information governance and the different technologies employed at each trust, but we are very nearly there now. And studies have shown that there's little evidence that routine follow-up identifies disease reoccurrence, yet it's costly and time-consuming. Therefore, the national guidance encourages stratification of patients onto follow-up pathways based on risk. The only really successful way to do this is to manage patients on a digital system, which is secure, where patients are not going to be lost to follow-up, as we know that spreadsheets and pieces of paper are not a long-term effective solution, and they're certainly not foolproof. So for urology, we've currently built PSFU pathways for prostate, which is nationally mandated, bladder and renal, and Infoflex that will allow hospitals to track patients on follow-up in a straightforward, easy to navigate way. And as part of my role, and that the system specialist in Infoflex will be able to support trusts with what they need us to do to help them stratify patients. We'll be out there training the different tumour groups to use Infoflex. We'll be supporting them in how to set up their clinics where they're not already running stratified follow-up. And then once for the long term, because we're employing a system specialist for Infoflex, they'll be able to build e-learning so that the system is supported for the long term, and that anybody new starting will also know how to use it. So whilst this slide is a bit busy, I just wanted to say that the protocols show you how the protocols for each tumour group are developed. I feel it's just important to clarify that every stage is worked on with the clinical teams. Clinical teams design the protocol, which is signed off by the pathway board, and then the Infoflex design is built with their input at every stage. And we found that that's typically been 3 meetings of about 2 hours in length each, so it's been quite a commitment. The protocol for each tumour group is then tested by the users, and then it's taken back to pathway board for final endorsement. And in the future, we expect these protocols to change as treatments change, and it will go through that same process. But because it's a system across Greater Manchester, that change will be managed carefully because, if NCA requests to change, it affects every hospital. But we're going to have a process in place to manage that, and also the skills in-house to keep developing this system. So what are the key principles of PSFU? So we can see from this slide that personalised care and PSFU cannot be properly successful without getting all parts of the puzzles in place. Giving the patient information about signs and symptoms to look out for which could suggest their cancer has recurred or progressed. We need to ensure that they have rapid access back to their cancer team, including telephone advice and support, if they are worried about any symptoms, and also have regular surveillance scans or tests as dictated by the protocols, with quicker and easier access to results so that any anxiety is kept to a minimum. And no matter where you are in Greater Manchester, the way you're followed up is going to be the same. And it's also about optimising the workforce's skill mix as well to make sure that support workers can release CNS's time for the more complex patients. Sorry, something's moving behind here. So there's many benefits that PSFU will bring to patients, and we're monitoring how that's delivered to ensure that we don't create any additional inequalities in healthcare and that we do enhance the patient experience. Also on this slide, I'd just like to point out the estimated figures on the bottom right-hand side, that for every 1,000 referrals for prostate, approximately 400 outpatient slots can be redeployed when a patient's put onto PSFU. Now, these were calculated using estimates on the portion of patients being placed in self-management and on the redeployment of outpatient appointments. But they are based on published pilot sites and local implementation studies, and were judged to be realistic. We're hoping that Stockport are going to trial the modelling for us so that we can start to get some data for Greater Manchester. But this figure from the pilot does show that there can be real potential to assist with the long-term recovery plan. So finally, I just wanted to put up my favourite slide, which is our team. So we are a new team, but we are now a team of 6. So we really do have the resources to support trusts and really embed all aspects of personalised care. And sometimes for the patient, make the unbearable bearable. Thank you.
It's getting full at the front, isn't it? Last but not least, we've got Dorothy. Dorothy, well known to many people in the room. Dorothy's going to give a patient perspective. Thank you, Dorothy. So, thank you very much.
Hello, everybody. Thank you for inviting me. I'd just like to give you a brief overview of my experience of being a carer and the involvement with cancer and carers. Prior to my retirement, I was a Macmillan uro-oncologist CNS at Bolton. A large caseload of my patients were men diagnosed with and treated for prostate cancer. Looking after these patients, I realised how much partners and families all played their part as carers. My story as a carer started following my husband's cancer diagnosis. His family have a history of prostate cancer. Both his brother and cousin were diagnosed and treated for the disease. My husband and I suspected there was a good possibility that he may also develop the disease at some point. However, we did take comfort from the fact that he was being monitored by the GP with regular PSA testing and rectal examinations. And this went on for several years. However, after worsening urinary symptoms, John was referred to the urologist, and following investigations, prostate cancer was diagnosed. Albeit expected, it came as a shock to actually have the diagnosis of T3 disease with a Gleason 7 and PSA of only 3.4. And this was the start on that cancer pathway. The experience for me as this carer brought all the highs and lows a cancer diagnosis creates, both mentally and emotionally. Dealing with my own thoughts and feelings while supporting John was sometimes difficult. I had the knowledge of the disease, but when you're part of the equation, it certainly makes a difference. The whole diagnostic process, as we know, involves many appointments, travelling to different hospitals, undergoing scans, awaiting results, discussing and considering treatments and the side effects, and wondering what life will be like beyond treatment. I had years of knowledge of prostate cancer, but the sheer volume of information was difficult at times to retain for me, and even more difficult for him. In spite of our many conversations, my explanations and diagrams. But the main aim, as it is for most people, was to get rid of the cancer. Once the decision was made and the surgery was over, it was reassuring to know that the cancer had been removed and the recovery could begin. On reflection, it was good as a carer to have a voice in the decision making, although I do believe that our perceptions of the disease, treatment and outcomes varied widely. John admits he could not think past the diagnosis. It was a surreal experience. He then described euphoria, knowing the cancer had been removed. The treatment outcome from the surgery meant making adjustments to life for both of us. The cost of caring creates many hurdles, both emotionally and financially. There were continence issues, changes in body image, low energy levels, fatigue, erectile dysfunction, low mood and mood swings, and also poor esteem for him. For me, I felt the loss of that person I had known. It was difficult to be completely open and expose your problems to anyone as a carer. And there is a sense of disloyalty to your partner should you choose to do this. In spite of everything, it was a line I did not cross, but sadly, the cost of cancer can and does impact on relationships. Sometime later, during the follow-up period, the cancer recurred again. We were back on that roller coaster of highs and lows of the cancer pathway, facing treatment decisions about salvage radiotherapy. Following the completion of his radiotherapy treatment, Macmillan had introduced the recovery package, which a few of the team have alluded to, which, as Andrea explained, involved the holistic needs assessment, the treatment summaries, cancer care reviews, and the health and well-being event with personalised care for patients and more support for carers. This was a great help, and it gave permission in some way to talk about any problems and be signposted to other services. So onto the cancer pathway. As we all know, the cancer pathway has many twists and turns. We know it as the start of the diagnostic and treatment process, but it's not just a sequence of appointments and treatments to complete the 6162-day target. And it doesn't finish there. It includes much more than a path for patient and carer, more like a continuum, ensuring they receive a full and detailed explanation and fully understand the diagnosis, the treatment options and side effects of each treatment, helping them to continue to live well. Often things are explained quickly, and easy access to health professionals is not always possible. Literature is given, but is it ever read? Contacts for national helplines are given. Is the information ever always understood? Acceptance, adjustment, and understanding of a cancer diagnosis is an individual thing, and not all information is retained at one consultation. As in my husband's case, both patient and carer needs access to knowledgeable healthcare professionals. Often carers needing more help to support both themselves and their partner, and ensuring all parties fully understand each step after treatment and where support is available. The pathway does not end suddenly once treatment is delivered. Supporting and signposting patients and carers to other services contributes to a good recovery and helps them live well with and beyond cancer. In spite of this, services do seem to vary within localities, often with long waits and postcodes which can deny access to specialist services. So my story begins as I became a carer rep on the Pathway Board. I had felt I joined Greater Manchester Cancer Voices community some time ago as a means of support for myself There were opportunities inviting anyone affected by cancer to get involved. And I felt this would help me. There was very little around carers support, and at that time it was noticed that service users needed a more powerful voice to raise comments about their experiences, about what went well and things that didn't go so well, in order that improvements may give others a positive experience. For me, this was the right time to get involved. Individuals seem to choose a time to get involved. During treatment may not be appropriate, as they may not be in the right frame of mind to reflect on needs for change, or say what went well or what didn't go well. Getting through whichever diagnostic treatment stage is the main objective. I have been involved in many projects within the Greater Manchester community and feel fortunate that I am now a carer representative on the Urology Pathway Board, where I am able to raise issues which may have been overlooked by health professionals. The late effects of radiotherapy being one example. Also, as part of the prostate small communities, a local Bolton Prostate Cancer Support Group and Bolton People Affected by Cancer forms a link which joins many people and their views together and can be powerful, influencing developments to services. Getting involved in projects and through feedback can ensure how effective new innovations prove for patients and carers. Thank you.
Thank you, Dorothy. I'll come to you first for a question in a minute. Let you collect yourself a second. Have we got another microphone roving? Because I know, is Struan still here? Put your hand up if you're still here. There he is. There's a prompt out there just to try and get someone else to ask some questions as well. Thanks, Struan. I'll come to you in a few minutes. So one of the themes from this morning has been all the acronyms, hasn't it? I've just written a few down. GIRFT, PSFU, HNA, just to name a few we've heard this morning, but in particular the workforce. This is really a workforce and pathways session, this one. And I've written down the ones that I've heard. This is in the nurses kind of section, if you like. CNS, AHP, AP, AMP, SCP. I stopped at that point. Doctors, we've got FY, CT, ST, SPR, SAS, Trust Grade and Associate Specialist. I mean, isn't it crying out for some unifying of this with perhaps 3, maybe more, maybe less, curricula, and then you go along each of these with a unified curriculum and able to get accreditation in a simple, transparent process. It really is crying out for that, isn't it? Maybe something we can develop with our panel here. So, first off, maybe to yourself, Dorothy. So quite uniquely, you've been a urology specialist nurse, and you're also seeing things now from a caring perspective. If you could wave a magic wand, what's the one thing you think we all need to do a bit better?
Well, I think from this morning's presentations, you're demonstrating it's being done. The things that I've mentioned of the improvements are happening. And I think particularly, Craig, I like the mention of the survivorship. I think that is important because of all the changes that cancer does bring about.
Yeah. So good, thank you. So very positive, well done everyone. So my stooge, Struan, step forward.
Is this working? I'm Struan. I'm one of the urology specialist trainees. Thanks for the presentations. I think my question is, as rotational trainees, as Craig alluded to, it's quite difficult when you're only spending a year in a department, and there's quite a lot of frictions I tend to find with non-doctors or advanced practice. I think from a CNS perspective in particular, and also for Nick, have you come up with a way of having an induction for new doctors coming to the department so that you can introduce yourselves and work out how you can all work together best? I tend to find when I join a new trust, I tend to meet people on the job. So if I'm diagnosing somebody with a new diagnosis of cancer, I'll then spend time with the CNSs. I'll walk into theatre, and if there's an SCP there, I'll meet them then. Have you thought of a sort of an induction process, maybe for rotational trainees, so we can work together better?
To be honest, we don't have anything in particular. I think Ewan used to do the instructions for the new staff, the new medical staff, and it used to be a case of that. I think we used to have our pictures on there and a bit of a blurb about us, but that and the guy used to do the coffee as well. I think he was highly pointed out as well, Zoltan. But there was no specific for us to be there on the day, which is probably, in hindsight, would be better if it could be worked in. I guess it's difficult to probably get everybody in one place at once to meet. So I think that the conscious thing for me is that, like you say, Struan, when you do come to theatre, where we get introduced by the consultant if it's the first time, or we do have a chat. Because as I put on that slide about the conflict, the big thing really is about communication between me and the trainee, and also between the consultant and the trainee and the surgical care practitioner in my case. So we understand where we all are, what our needs are, because we've all got needs on our training or our development, or even in regards to the service plan. So that communication is the cornerstone of anything going forward. And it runs across healthcare in general, but that's what I try to encourage for all the SCPs, to try and avoid the Twitter meltdowns that we see, because that's not the place to have the communication. It's to have the face-to-face chat, so they don't generate this further down the line.
I mean, we've done some work in a lot of talk about Northern Care Alliance this morning, but a lot of the panel are from there. But done some work with some of the doctors in Northern Care Alliance, and the induction in general for all doctors, new consultants, new trainees, locally employed doctors. It's just not good enough. The induction isn't fit for purpose. It needs to be better. It needs to be more bespoke as well for the department. So there's always room to improve induction, I guess, for all members of staff. Can I, there's Pod, I can see you out there. Could we give the microphone to Pod? Pod, I just want, in a minute or two, I wondered if you can think about a question for the AHP. Oh, you have? Excellent. Because there's a lot of talk about doctors and nurses here. I'm aware that we have allied healthcare professionals. Just want to make sure that we're thinking about that group as well.
So I am a clinical psychologist, not an AHP, sadly.
Sorry.
I'm not skilled enough. But as I sat and listened to this amazing panel in front of me, I kept thinking about what would I want to ask, given the range of professions and the adage that prevention is better than cure. What one tip would each of you want to offer in relation to reducing iatrogenic harm to the patient and or their carer when it comes to emotional health? One thing you think that works, that you can do as a profession to reduce that emotional harm that comes with building up to and getting diagnosed with and then being treated for cancer.
So let's keep with the clinicians on the panel. Let's not be too harsh on Andrea. Liam, do you want to start? One sentence.
Good communication starts, right at the start. Be open and honest with people. Don't dance around with words that don't mean anything. We've heard too many acronyms today already. Just communicate. Be open and honest.
I'm sorry, Nick, that you're last here. Your ideas will be... Yep, okay.
Mixed messages. So one clinician saying one thing and then another clinician saying another thing. So we all need to be on the same page, because that just causes loads of confusions with patients. And then clinicians, perhaps, so an example could be perhaps trainees not talking about oncological treatments in a sense, leave that to the oncologists. Because from a CNS point of view, when you go in to speak to a patient and they've been given the diagnosis and then they've had discussions around treatments, and then they'll see the oncologist who may say something different. And it just again causes confusion.
Yeah,
So,
no
so
thanks. You were staring at me a lot when you were saying that. You don't see me anymore. I hide away from you. Sally?
Referring to your CNS as soon as possible. We find that sometimes, they've seen everybody else, but that none of the patients have seen a CNS. So it's important that, CNS is told about the patient's new diagnosis as soon as possible.
Craig?
Communication is really the key. It's a hard metric to measure, though, in terms of these softer. It's only now that clinical trials are really focusing on quality of life and the impact of treatments, not only in terms of survival, but on survivorship. And I think if someone can generate a good test to see how someone feels, and this is where involvement with a clinical psychologist is brilliant. I think we should have more evaluation of these, not just when it's patients are struggling, but right at the beginning, and talking to patients more right at the beginning of their cancer journey.
Obviously, all of what's gone before, but I think the key thing for me is listening to the patient, because for us, this scenario that may be in front of us, we've heard 50, 100, 1,000 times. For the patient, this might be the first time. So I think listening to them and how it applies to them, and not to, and I'm sure we don't do this, but not to just go into our usual pattern and go ream off what the treatment is and what the process will be, but listening to them and anything that you can then cater and shape the conversation around what is important to them while getting the key information across. It would be my, in a sentence, very long one.
Yeah. Okay, thanks. Thanks, Pod Struan, for answering. Any more questions? Put your hand up. Molly, have we got? Well, she's on her way back to Molly. Liam, can I ask you a quick? It's not a quick question, but I guess you've not got much time to answer it. Primary and secondary care are always seen as separate. The GPs are doing this. You probably refer to the hospital doing that, and you don't want a load of workload, and the hospital doesn't want. And there's tension there, isn't there? How do you envisage in urology cancer we can change things to try and break that barrier down?
Probably acknowledging there's a bit of a problem there, and then actually how can we work forward together. So, for example, in my primary care network, we have, one of my primary care networks has a gynecology service, for example, that has GPs who have got special interest in gynecology. They can have some referrals that would normally go to secondary care. They can go and see the GP with special interest first of all. That's a sort of a way of actually, and they work closely with the hospital colleagues. And I think there's perhaps models that you could look at there, saying, there's going to be GPs who are interested in something. Let's develop that. Potentially with some input from trainees or AHPs, etc. Say, can you use your expertise into primary care for a little bit and just work, I think, a bit more collaboratively with the resource that we have to do that.
Yeah, one idea I heard was within each department having a primary care liaison nurse or doctor who could facilitate the conversations. There's lots of other ideas there, isn't there? Molly.
Thank you. I suppose a question mainly, I suppose, to Sally and Laura, but Craig, Nick, interested to hear your thoughts as well. We know that workforce and education very much go hand in hand, and we're doing a lot as a Cancer Alliance to tackle that. We've already got the academy, and we're looking at what we can do to embed that lifelong culture for the people who are already in the workforce. But you've alluded to the fact that we need more people to come through this, and Ascend is great for the people who are maybe starting out already, but what about the untapped workforce? What more can we do there? Like, are apprenticeships the answer? What do you think we can do to get more people through the door?
I think it'd be good if we could get into universities and sell urology in a sense. I think that would be helpful. And go and talking to the nurses who are in the final year, who are coming to that point of transition into being a registered nurse, and just talking about specialist practice and the roles. That would be really helpful, because often what we find is when they come into the clinic, they don't really have an idea of what a specialist nurse is and what we do and how we help patients. So I think that could be covered more really. That'd probably be a way of, what do you think? Yeah, that's a good idea.
Yeah, that's a fantastic question, really. I think the thing about healthcare is the changing face of healthcare and how it's delivered. And we've seen roles really emerge that didn't exist 5-10 years ago. So people who are trying to decide what profession they want to go into, it's such a difficult decision, and the vocational careers like being a doctor or being a lawyer are quite easy because you kind of embark on that journey and it's where you're going to end up. But I think some of the changes that have happened, I think really raising awareness. I still have struggled kind of knowing where each AHP, HAP fits in the medical workforce, and a lot of people identify that they want to go into a healthcare role, but what does that mean? Is it direct patient facing? Is it more a managerial leadership role? And I think just raising awareness that there are lots of options might help. And bringing it early, so don't do it when people have already trained and they're already in a profession. Go earlier, go to school and say, look, these are potential opportunities for you to work in healthcare, not necessarily dealing directly with patients, but working in a system or in a GM Cancer Alliance type thing.
Yeah, I've got a couple of questions myself about recruitment and retention. I've got a bit of an interesting workforce. So first to Laura and then Nick, the same question. And you both spoke about it. Laura described it in a more challenging way about recruiting more CNSs. You don't have the ward, you said. You don't have the feeding ground. So we clearly need more CNSs. We clearly need more advanced nurse practitioners or advanced practitioners from the nursing community because the practical experience they bring with them. How can we do things?
So I think as CNSs, we all need to be evaluating our service. And the problem is no one has time to do that. And by doing an annual report and pulling all your data together, it is really helpful because it helps you to sort of work out what you need. Because we're just on this treadmill all the time. We're just so busy all the time. And it's just about stepping back and looking. And from doing that, we've done it 2 years in a row now as part of our sort of Macmillan service review. And just looking at the figures and the numbers about how everything is going up, it's really powerful. And hopefully, from the work that we've done, we're going to be able to hopefully have some application to get some more CNSs in our department because that's what we need. But I think, we all need to be looking at our data, looking at our clinics, looking at how many patients we see and what we deliver and reviewing it and pulling it all together. But it just takes time. It's not quick.
No. And then Nick, you described, wouldn't say easier, but you talked about a recruiting ground in theatres, but you described a broad-ranging job plan where you're in theatres, clinics, potentially on the wards as well. So where do you see people following in your footsteps coming from, and how would you increase the number?
Well, like I said in the presentation, theatre is a breeding ground, and if you want to stay clinical and have a career progression, quite often the surgical care practitioner is the role for them, be across whichever speciality. With that can be a bit of a shock for some of them, having to the ward in a clinic if they've spent 10, 15 years in theatre. But you have to be honest with them from the start that the role crosses various environments. I think first and foremost, we're ambassadors. So all we can do is, by what we do as an SCP or a CNS or a trainee doctor, is to inspire the people you come across. And Craig mentioned in his presentation that FY years was when he thought, I want to become a urologist. So it could be that we come across a student nurse or a student ODP on my travels, and I sell them the role of the SCP at that point. And maybe, yes, they're not going to become an SCP tomorrow, but I've planted that seed. And I'm sure we all do this, but it's just taking that time to explain our roles when we can and demonstrate what we can do, because we are the best ambassadors for our roles. And I think that's the key thing for me going forward.
Okay, well, thanks very much. I think we're out of time now. So can you join me in thanking the panel for...